Treatment resistance and violence. What if clozapine does not work, or you cannot prescribe it for medical reasons, or if the patient refuses to take it? Commonly used strategies for treatment resistance and violence are high dosing, use of two concomitant antipsychotics, and augmentation of antipsychotic with mood stabilizers. Violence that is linked to psychotic behavior despite standard antipsychotic dosing may be caused by inadequate occupancy of D2 receptors due to pharmacokinetic failure, that is, drug is not adequately absorbed or it is excessively metabolized. Diagnosis of this is possible by measuring therapeutic drug concentrations. The treatment solution is to raise the dose above the standard dose in order to compensate for the low amount of drug getting to D2 receptors. This chart shows various brain areas related to psychotic aggression and its clinical remedy. Psychotic aggression in positive symptoms is related to mesolimbic area, and the remedy is to increase the striatal D2 occupancy more than 60%. Psychotic aggression in negative symptoms is related to mesocortical and prefrontal cortex area, and the remedy is the same as with positive symptoms. Psychotic aggression in affective disorders is related to VMPFC, and the remedy is mood stabilizers. Impulsive psychotic aggression is related to OFC and amygdala, and the remedy is similar as the positive symptoms and negative symptoms. Cognitive or instrumental aggression and violent psychopathy is related to DLPFC and can only be improved by behavioral treatments, seclusion, or incarceration. Pharmacological failure is to have adequate clinical response despite attaining 60% or more striatal D2 occupancy. One cause can be that the patient has an affective disturbance that requires augmentation with mood stabilizers, especially with divalprox or lamotrigine, but even with lithium or an antidepressant. Another approach is to wait for their clinical effects to kick in and use time as a drug and treat for many weeks hoping to get a good outcome. But as can be expected, there is no way to predict this. Another approach suggests that some patients require much more than 60% D2 occupancy to have an adequate treatment response. And a way to target that is to use standard doses of two antipsychotics at the same time. But then patients can have intolerable side effects, most commonly sedation, EPS, weight gain, but occasionally paralytic ileus, especially with very high doses of pain, such as clozapine, quetiapine and olanzapine, as well as cognitive dysfunctions. Very high dose monotherapy or antipsychotic polypharmacy should be used sparingly and only in selected cases, such as treatment resistance and violence. Another group of patients with instrumental aggression related to sociopathy and antisocial personality disorders, no amount of D2 antagonism is likely to help, and as previously stated, might need behavioral treatments, seclusion, and incarceration.